So after listening and watching marvels in the structural interventions, we are back to the basics. Basic in the means syncope is a very, very fundamental topics, and it is every one of you sitting here also would have experienced it, would have treated the patient, would have come across in your practice many patients coming to you with the syncope episode. It's very important for the clinicians, for it doesn't matter what is your qualification, to understand and diagnose the syncope and treat them appropriately or refer to the center where the facilities are available for the appropriate evaluation. So we are going to talk about, I'll involve the panelists also to discuss. So what are the ways, very clinical, real life clinical examples, how we make a diagnosis, how the patient present to us, and how are you going to take it. So the first thing is diagnosis by definition is very important in syncope. The syncope, the fundamentals of syncope management is history. The history taking is very important. You have to spend time to analyze the history. There is no umpty number of diagnostic imaging you can do it, but you cannot establish a diagnosis without understanding the history. So the history starts with what is a syncope. Transient loss of consciousness due to cerebral hypoperfusion, characterized by rapid in onset, shorter in duration, and spontaneous complete recovery. Each word is a self-explanatory, which is very important to understand. It should be a rapid in onset, shorter in duration, complete recovery is very important. So what is with transient loss of consciousness? How do you define the word transient loss of consciousness? The patient is not aware of himself, is totally unconscious, he loses his motor control, he slumps or falls, get injured, totally unresponsive, but he recovers completely. He is able to communicate and able to get up and able to talk to you immediately within few minutes. That complete recovery is the word is very important. Shorter duration, complete recovery. In that period of loss of consciousness, total amnesia. These words are very important to label somebody as a syncope. He had a syncope. So because many times, though, I will take you to the case and how it get confused. So why we should discuss about this syncope? Half of the patient coming to OPD or admitted in any hospitals going home without making a diagnosis why they lost conscious. Nobody is able to give proper reply to them why they lost conscious. That's very important. The most important thing is if you lose the patient or if you are not diagnosed the patient which has lost consciousness due to cardiac origin, the mortality is 10 times higher within 6 months. You will not able to see him again. The chance of seeing him again reaching the hospital is very less. So the cardiac cause of syncope is very high mortality. So one has to evaluate very carefully. Even though we know that the vasovagal syncope is the most commonest syncope, which is a very benign in nature, I will tell you. But why the focus is more important on the evaluation is you should not lose the patient who carries a high mortality, which you may not be able to see him again coming to you. So let me put the case example. This is a 19-year-old male, had 3 episodes loss of consciousness. So wherever I am using the word syncope, it fulfills the criteria for syncope. Then only I am using it. I defined it already. The same criteria applies. One is due to COVID infection, other is due to gastroenteritis, other is due to post-snake bite. And he also has an elaborate history, and he has one more episode 8 years back, similar things. All the episodes are preceded by giddiness and blurring of vision. There is no chest pain, no palpitation, no injury, no fall, no involuntary movements, no incontinence, or no tongue bite or nothing. So this is a common scenario everyone would have come across. I would like to take Dr. Rajeshwari's opinion. How do you go about this history, madam? From the history, someone comes to you. What do you think?
Karthik, this patient, I think 8 years history of syncope, very sporadic episodes, and most of the episodes followed some gastroenteritis or post-snake bite. Most probably could be vasovagal. I would like to say because no structural, did you do an ECG echo, anything?
Yeah.
No structural heart disease.
Yeah.
So 19-year-old, first episode 8 years back, then now following infection, dehydration, hypotension, most probably it must be having significant postural hypotension. So this can cause, or vasovagal symptoms can cause syncope.
Yeah, so
I feel most probably this is vasovagal.
Correct. So what is more important, again I mentioned the history taking. So without moving to any sophisticated investigation, from the history itself we can establish that, rightly Dr. Rajeshwari put it, these are the patient who had a clear history of, reflex syncope or vasovagal syncope. There is a premonitory symptoms, blurring of vision, he loses consciousness. There was a reason behind it, gastroenteritis, fever, loose motion, any of these maturation syncope, situational syncope, defecation syncope, cough syncope. These are the things from the history. There is a clear precipitating factor would have been there. Then they get the prodrome symptoms. Then they lose conscious. And within a few minutes, they'll get up and walk. Every one of you sitting here would have either would have experienced or would have come across the patients who experience these symptoms. So these are all low-risk patients, and there is no life-threatening is not involved, and the only history we can make a diagnosis. There's all the enumerated, so many conditions are enumerated: maturation, defecation, cough, postprandial, crowded place, hot places, in the train or bus, or so many places people lose conscious due to the situations. And in this patient, unfortunately, every patient loses conscious in our country or in many countries go to the neurologist. Because something they mean conscious means something related to neurological. Because they are losing conscious, they go to the neurologist. Invariably, they get the MRI done and EEG done. It was normal in this patient. And ECG echo Holter also was done. And because he had 3 episodes in the span of 10 months, he was put on anti-epileptic medications. So what do you think, Dr. Aruna? This is a common scenario. These are all real-life cases. So this is what we see in the practice. Somebody loses repeatedly conscious, every investigation normal, they put them on anti-epileptic medications.
So before putting on anti-epileptic medication, they should have done a EEG, and they should have a proper documentation, whether it can be a sleep EEG or it can be a provoked EEG, and all these should be done, and then only they should be put on proper medication.
Yeah, the importance, the limitation of EEG is very, very important. In an epileptic patient, the EEG may become normal. In a non-epileptic patient, EEG may become abnormal. EEG is to be interpreted, every neurologist to agree with that. We had many discussions with the neurologist, to be interpreted in the context of the patient. So just because EEGs, we cannot treat the EEG alone. But in this patient, EEG also normal. This is a common scenario that when somebody is unexplainably losing conscious, they just put them on antiepileptic medication just to counsel the patient. The patient also should feel something they are given. But it becomes a stigma, and the patient will be lifelong antiepileptic medication or many years on lifelong medications, and it has a side effects. What will do this patient? Anything you can do, Radha, to this patient? How do you prove that this patient is a vasovagal and not the epilepsy or anything? Because the family is very anxious, because within 10 months, patient lost conscious 3 times. They want some answer from you.
In this patient, we already have ruled out any presence of structural abnormality by doing an echo. Also, there's no rhythm disturbances on Holter. So the most feasible test we can do here is a head-up tilt table test, which helps us in probably if there's if we can confirm the similar episode when we do a tilt-up table test, it actually tells us it probably is a vasovagal episode, what he has undergone before.
So that's what she rightly put it. Even though this scenario is diagnosed, can be made in the history itself. You don't need no sophisticated investigation. For the sake of completion, we can do ECG, echo, and MRI. But we can stop with that. No, even I don't recommend even MRI also. We can stop with that, the clinical history. But the family here is anxious. They want to know the answer. Because they don't just listen to a reassurance or encouragement. Because one episode they would have listened to you. Now the 3 episodes have happened, they were very anxious. Every patient coming to you, they expect something from you. So this is a tilt table test. We do it, put them on upright position and just watch for 20 minutes and provoke with the nitroglycerin spray. And one has to, a lot of controversy about this test of late, but one has to understand the limitation. There are false positive, false negatives can happen in this test. It should be done in appropriate protocol. But the aim of doing this test in this particular patient is, the patient loses consciousness on table, he will understand that. I am not suffering from epilepsy, the family understand that. I am dropping my blood pressure instantaneously and along with the heart rate drop. There is called neurocardiogenic reflex syncope. That is why I am losing conscious. Then he will listen, he will preventive measures. What would advise you, Dr. Rajeshwari? So in this patient to prevent subsequent episodes. Definitely we know that is not the antiepileptic medication, not the things we can stop it. But the thing is, family wants some answer. How can I prevent it?
What was the tilt table result? Vasodepressant or cardioinhibitory?
It's a mixed response.
If it is, okay, I will just say, maintain good hydration. If at all needed, to avoid prolonged standing, maybe stockings to the legs while ambulant, unless patient has significant brady, causing cardio-inhibitory response. It is only vasodepressant response and mild fall in heart rate. We need not do anything other than all this.
So the most important thing is, the patient education is very, very important. Vasovagal syncope or reflex syncope, which I told you, lot of condition maturation, defecation, cough syncopes, and prolonged standing, dehydration, all those things. Reassurance and preventing understand the precipitating factor, prevent the precipitating factor, and reassurance is the treatment. There is no medication for this. No proven medication is available. If you are subjected to that provocable situation, you will lose conscious. This can go on. The patient coming at the age of 40 years, 50 years, when they go back to the history, yes, I was fainting in my school days. So this history goes on. So the main thing is make them understand preventive measures to follow, avoid dehydration, appropriate, and yoga plays a very important role. And there are a lot of enough papers are scientifically proven that yoga prevents it because strengthening the muscle and some counteractive measures you can do it during that. Basic thing is hydration, avoid the precipitating factors of treatment. There is no medication, and tilt table test should not be used as putting a pacemaker or anything. This is only to reassure or confirm it because it has a loss of positive, false negatives. It should be interpreted very cautiously. It should be used to make the patient understand and explain them the preventive measures. Let me move on to the second case. It's an 82-year-old man. That was a 19-year-old boy. Here we are dealing with the 82-year-old male, post-aortic valve replacement done in 20 years back. And he was brought to the emergency with a staring look, with the lying, and he was unresponsive for 1 or 2 minutes, associated with some sort of stiffness in his upper body. He had a similar episode in the last 1 year, repeated episodes. He was evaluated elsewhere, and Holter was done twice. It was normal, only PVs were there. Because he was having some stiffness, he is losing momentarily loss of consciousness. Again, he was put on anti-epileptic medication. But while taking also, he was getting these episodes. Family accepted that, okay, 82-year-old man suddenly loses consciousness while lying. Yeah, again, he comes back and talks. So let it be go on. But one fine day, he was getting a recurrent episode, 4 or 5 episodes in a single day. They brought to the emergency. His echo showed moderate AS and normal LV function. If I ask, what are the high-risk factor? So the patient, who comes to you in this history, again, I re-emphasize on the history. In this history, what is a high-risk factor for this patient to lose conscious?
He is an 82-year-old male. Age is the first risk factor. He is a hypertensive diabetic. He can have a coronary artery disease, and also he has an aortic valve replacement. And there is a chance that there will be a compression of the aortic valve by the surgical valve. So we have to be more careful in diagnosing and treating this patient.
Yeah, the most important high risk factor, the red flag. These are all we call red flag sign. And somebody syncope coming with this sort of histories, there are red flag sign. High alert. You cannot discharge the patient from the emergency. You have to admit them and evaluate. What are the high risk factors? Means that is a cardiac is the culprit for his syncope. New onset chest discomfort, breathlessness, abnormal USC, pulmonary embolism presenting as a syncope, MI presenting as a syncope due to VF. All those things are high risk factors. Somebody losing consciousness in a supine position. That patient was losing repeatedly in supine position. Again, your reflex syncope is ruled out. While supine position, nobody is going to lose. Blood pressure is not going to drop reflexly. So this supine position, loss of consciousness. Any palpitation immediately followed by loss of consciousness. These are the very high risk signs. Somebody is already structural heart disease. Like in this patient, aortic stenosis, somebody suffered already old MI, EF is low. In those are the patient coming into the sudden loss of consciousness momentarily like 1 or 2 minutes, then they become abruptly normal. The family not even bothered to take him to the hospital because anyhow he is going to recover. They are fed up of going to multiple times to the hospital. They will just accept it. These are the high risk signs. When he reached to our emergency, this was his baseline ECG. What is that from the ECG? What is the suspicion in this ECG, Radha? Anyone do you want to comment to this ECG? So ECG shows, this is a right bundle branch block. Many of you are aware. This is a patient, you can see the V1, right bundle branch block with the left axis deviation. That means the patient is having bifascicular block. The patient who has a bifascicular block, that is out of 3 fascicles, right bundle and left anterior, left posterior, the 2 fascicles are already blocked. He is surviving only on 1 fascicle, which is left posterior fascicle. When he comes to this sort of history, coming to the emergency repeatedly, one has to have a high suspicion of intermittent high-grade AV block or complete heart block, making him unconscious. That suspicion should come to the clinician mind. Just because one Holter is normal, it is not going to rule out that possibility. Because patient is not getting syncope every day. So when he came to the emergency, already complete heart block was there. So this was a pacemaker was implanted. It just then after that, no more symptoms. So the importance here is the ELR. If the patient, instead of relying on the 24 hours monitoring, you should go for a 1 week or 2 weeks monitoring with the yield is very high in these patients. Just don't believe the 1 day monitoring, go for a nowadays easily 1 week, 2 weeks monitoring we can do, so that by going by ELR, we can pick up this patient. I can show this patient again, bifascicular block with repeated syncope. So when he came to us and with the Holter, normal Holter, but the history was classical of cardiac, when we monitored it, then it was intermittent high-grade AV block, complete heart block was going. Another patient, again Holter was normal, syncope, when you put him on 1 week monitoring, long sinus pauses, tachybrady syndrome. So the basic is yield of long-term monitoring is more in syncope compared to 24 hours monitoring. Often we see they put the 24-hour monitoring, give the clean sheet, patient go to the neurologist, again get the antibiotic medications. So long-term monitoring plays a very important role in this patient. In cases even the long-term monitoring not result, EP study plays a role. The patient with a bifascicular block, LBBB or RBB with LHB, you can subject them for the electrophysiology study. We can check the conduction system across the AV node and bundle of his. If the conduction system is impaired, we can demonstrate that they are having the prolonged HV interval or the patient having infraction AV block. EP study plays an important role in this patient. The role of EP study in syncope is those patients having underlying bundle branch block, those who have suspected sick sinus syndrome, or the patient who has a low EF but could have been lost conscious due to VT, which is not able to demonstrate that, or the patient who has a SVT with hypotension. These are the possibilities. When you suspect somebody gets, I said, palpitation, then losing conscious, you don't know they're dealing VT or SVT. You can provoke them and stimulate the EP study and see that if there is any inducible arrhythmias are there. So you can assess the sinus node function, you can assess the AV node function, you can assess the inducible arrhythmias. These are the roles of EP study in a syncope patient. This is another example. This is a gentleman with hypertension and no premonitory symptoms, no clear precipitating factor for vasovagal syncope. Twice had a jerky movements during loss of consciousness, all while sitting. Okay, and once he had a sustained injury. You can see all the reports are normal. ECG, echo, Holter, TMT, HUT, even tilt table, everything negative. EEG was normal, MRI was normal. What are you going to give answer to the patient? While sitting, he lost 2 times conscious, hit his forehead in the dining table itself, and got badly injured. So these are the patients we will come across. These are the patients that are ideal candidate for loop recorders. I'll take 5 more minutes. Insertable loop recorders. Okay, so these insertable loop recorders are designated for long-term monitoring. In this patient, these are the era before the long-term monitoring was like external loop recorders are not available 10 years back. When I inserted this monitor, this is like you can see that pen drive sort of thing. We can precordial region, we can put it, which records the ECG for 3 years. So when the patient is periodically losing consciousness, when your suspicion based on the history is highly suspicious of cardiac syncope, you can put this ELR which records the ECG. And then when they came to problem, and then when he got into, when he had one more episode, then he had a high-grade AV block. You can see paroxysmal AV block was going. Then he was given a pacemaker. Now almost 8 years over, 9 years over. Even I had to due for replacement. So he is doing extremely well, no syncope. So the patient who needs it unexplained syncope, there is an indication for ILR. But unfortunately, there has not been much awareness is there. Needy patients are not getting it. The patient who needs it, those who have bundle branch block, even the EP study is negative, you can offer them when you are suspecting cardiac syncope, or the patient suspected epilepsy but treatment is ineffective. And neurologists keep on adding it. 1 become 2, 2 become 3, 3 become 4. We have seen patients with 3 anti-epileptic medications. But unless the patient is in having a cardiac problem, he is not going to settle with the anti-epileptic medications. Like unexplained falls, recurrent unexplained syncope, or any of their severe form of reflex syncope. When you demonstrate reflex syncope with the cardio-inhibitory response in ILR, then they will benefit with the pacemaker, not with the HUT test or anything. So the patient who has a HCM or ARVD, primary electrical diseases, when you are suspecting high risk for sudden cardiac death, you can monitor them, the long-term 3 years monitoring. And these are the patients, other set of patients, postural giddiness and postural loss of consciousness, more common in these patients, the multiple antihypertensive medications or Parkinson's. You can see the chart, when they stand up, the immediately BP drops, the moment 164 lying drops to 120 while standing. When you continue to stand for 20 minutes, BP comes to 80. From 160 while supine comes to 80 in standing. Sometimes they have immediate orthostatic, some people have a delayed orthostatic hypotension. For this, you have to give, as Rajeshwari mentioned, stockings plays an important role, abdominal binder plays an important role, and then midodrine is nowadays available, alpha agonist. Those drugs can be prescribed to boost up their blood pressure, not to have this postural orthostatic due to autonomic dysfunctions. And this is another important patient, 60-year female patient, hypertensive, repeated injury. Again, you can see all the reports are normal. Again, Holter was normal. Patient was treated with the psychiatric medication, antiepileptic medication and psychiatric medications, because they believe that, she is malingering. She is not really losing conscious, she is malingering. When you put a 1 week monitor, and then this is what it showed, repeated tachyarrhythmias, and clearly they proved that during this episode, patient lost conscious. Then this is a tachyarrhythmia, patient not able to express the palpitation, but the palpitation comes, she immediately loses conscious. So people thought it is a psychiatric problem or epileptic problem. Then we took her and we ablated it, and now almost 12 months over, the patient is absolutely doing well, no more episodes, no antiepileptic, no psychiatric medication, nothing. And so this making a diagnosis is important. Before somebody labeling as a psychiatric episode or malingering episode, we should not leave any stone unturned so to prove that they are malingering. So we have to prove it, they are having any structural problem or not. This is yet another patient. You can see that again, 44-year-old female. These are all real life cases. Absolutely normal ECG. Holter was done for loss of consciousness, and only PVCs they found. Again, patient was taking, because of repeated symptoms, 2 antiepileptic medications. One fine day, she started losing consciousness, the stiffness repeatedly, rushed to the emergency. They thought it was a status epilepticus, started treatment for status epilepticus. When we reached our emergency, this was the PVC-induced polymorphic VTVF. These are all idiopathic VF. This was documented. So it's not that every patient losing consciousness due to epilepsy or epilepsy. So it's very important to know that PVC, when you are analyzing the PVC in the Holter, we have to see the coupling interval or-onty phenomena can happen. Closely coupled PVCs can trigger VF. That is the reason. You can see the VF or polymorphic VT self-terminating, they are losing conscious. So these are things, carotid sinus is often forgotten. These patients, elderly people losing conscious, if you touch the carotid, they will lose conscious due to long pauses. They will benefit with the pacemakers. And then WPW syndrome, it's a very important patient, lose conscious due to palpitation, AF with the fast, broad contrast. When they come to the emergency with the hypotension, the treatment is only cardioversion, and then long-term treatment is going to be the radiofrequency ablation to eliminate the accessory pathways. And then old MI patient coming to emergency with the syncope, documented VT, secondary prevention, ICD is very, very important. Somebody with structural heart diseases, old MI, LV dysfunction, you have to go for, ICD implantation when the VT is proved as a secondary prevention for sudden cardiac arrest. And then this is a patient with the ARVD. You can see the T wave is inverted V1 to V4, the syncope, and then this ARVD is proven. Then those patients with the VT, their high likelihood suddenly when they present with the syncope, again ICD implantation along with the antiarrhythmics or ablation should be considered in this patient. HCM patient can come to you with unexplained syncope. You can see the marked enlargement of the septum. We can see the very 25-year-old boy with the 40 millimeter thickness. So we have to give ICD to prevent sudden cardiac arrest in these patients. And Brugada again is a problem. Patient unexplained syncope needs treatment. And long QTC, most of this long QT syncope go to the neurologist for unexplained loss of consciousness, getting antiepileptic medication. Simple ECG will clinch the diagnosis of long QT. Then you put them on appropriate medications, which includes beta blockers, and then which will be treated these patients. So catalytic polymorphic VT, again, exercise-induced syncope is very common. We have recently encountered the patient. The child was climbing staircase in the school. Every time she loses conscious. Again, antiepileptic medication, when you put her on long-term monitoring, we found that it's a polymorphic VT is happening. And then we are appropriately treated with the beta blockers. So it's very important to run a syncope evaluation with all the facilities available. We have all the facilities available, and with our neurologist collaboration, we launched this year the syncope clinic to exclusively these things. So 90% of the patient you will get out with a vasovagal syncope, but 10% of the patient they'll be running with the pillar to post with the umpty number of investigation. Nobody is able to give any solution to their syncope. In those of the patient, we want to give some solution, explain all the possible investigation, including ILR and everything, all the investigative tools. We closely collaborate with our neurologist because most of the patients go to the neurologist only for the loss of conscious. We launched a syncope clinic to assess this patient, to give some solution to the patient. Maybe a simple problem, but if you come across the patient, they come with a big bunch of files where nobody is giving any solution. This is the solution for them. Thank you very much for your kind listening.
Thank you, Dr. Karthigesan, for moderating this session on syncope. Not to miss the obvious, Dr. Radha, Dr. Aruna,